right, welcome to each of you. Thank you very much for attending the Robert Allen Memorial Hematology Symposium. We have speaking today Dr. Gemlyn George, is a member of our hematology division, part of our general hematology group. He has been with us for the last a little over a year and a half. And came most recently from the Medical College of Wisconsin, where he completed his fellowship training. And he has an interest in patients, taking care of patients with hemoglobinopathies, which he's going to talk to us about today. So I'll let you take it away, Dr. George.
Thank you for those kind words, Tyler. In today's symposium, my objectives are to describe the mechanisms of polymerization in sickle cell disease, talk about the inflammation cascade in sickle cell disease, and describe the drug development and clinical trials in sickle cell disease, with really a focus on the inflammation pathway, which I feel has been sort of not really talked about in the last few years. So quick recap. In general, excluding other rare hemoglobin combinations, there are 4 major combinations or possibilities that can happen for sickle cell disorders. And of these, through history, the most attention has been paid to HBSS and HBs beta 0, as these have had the most complications and mortality. So what does this mean? Once again, to recap the physiology, there are 2 beta globin chains. And if you have a mutation that causes the S gene to be expressed on both beta globin chains, you have the HBSS molecule. And if you have one S being expressed and then no beta globin gene being expressed, that's beta 0. HBSC and HBS beta plus, as you can imagine, are a little better in terms of mortality and complications, but that doesn't mean they don't suffer other problems. For example, patients with SC do have pain, do have joint issues, do have retinopathy. But in general, they have better outcomes in terms of mortality and other organ complications. So to recap the physiology, as red cells traverse the microcirculation, oxygen is released from oxyhemoglobin, which are these red circles, generating deoxyhemoglobin, which are these purple circles. And deoxygenation of hemoglobin S induces a change in the conformation in which these beta units start to move away from each other. So you have these hydrophobic patches that are created at the site, which is one projection, and that starts to bind to the other hydrophobic site in the other beta chain. And as a result of this binding, what happens is a polymer gets formed. And this is essentially the interaction of 3 deoxyhemoglobin S molecules on one strand, along with the other 3 deoxyhemoglobin molecules on the other strand. And this is a top-down view. And this ends up forming something that looks like a Kern mantle rope that we use in climbing, and this huge polymer formation occurs. So as deoxyhemoglobin S polymerizes and these fibers align, the red cell gets distorted into this elongated banana or sickle shape as shown in this diagram. And because of this polymerization-induced membrane damage, as you can see, these polymers are sticking out, you have damage to the red blood cell, and you have an irreversibly sickled cell, leading to the complications that we know of. So what really influences polymer formation in the sickle cell? By the late 90s, we've learned that there were 3 things that really makes a difference: the cell's degree of deoxygenation, the intracellular hemoglobin concentration, and the presence or absence of hemoglobin F. And it's important to realize that both in the test tube and in the patient, fetal hemoglobin is highly effective in inhibiting this polymerization of hemoglobin S that occurs. And this is primarily due to the presence of another glutamine residue, which prevents a lateral contact in the double strand of the sickle fiber. Once again, to highlight the complications that can occur in this disease state, there are numerous organs that can get affected. I would like to point out to the audience that there are no myocardial infarctions in this population, but at least not in the classical sense where you have plaque rupture, and these patients tend to have a clean cath if you end up catheterizing them. But otherwise, all the other organs can get affected: the brain, the eyes, chronic pain, as we know, bones, kidneys, and more prone to infections, liver damage, and complications with pregnancy and with fertility. Now, recapping what predicts disease complications. And there are three things that we found out. Once again, it's fetal hemoglobin. Any increment in fetal hemoglobin was found to increase survival in sickle cell anemia. And patients whose hemoglobin F rose the most in response to treatment with hydroxyurea also fared the best. What's important to realize that about 30% of patients with sickle cell disease can have this coincidental alpha thalassemia, or mutations in the alpha globin gene. And these compound heterozygotes have less hemolysis. They have a higher packed cell volume, they have a lower MCV and lower reticulocyte counts. And now vaso-occlusive events are highly dependent on your packed cell volume. And so these patients tend to have lower rates of strokes, leg ulcers, better splenic function, decreased albuminuria, and all these things happen if you have coexistent alpha thalassemia. Beta globin haplotypes refer to the ethnic group or the geographic region from which patients originated. So patients that have had the Cameroon or the Benin haplotypes tend to have less severe sickle cell disease, or patients with the Arab Indian, for example, as opposed to patients who seem to have a founder mutation from Angola. So the treatment of sickle cell disease has basically can broadly be divided into these buckets, where people have targeted oxidant stress that happens because these cells get damaged, the cell adhesion pathway, the inflammation that results from damaged RBCs, the induction of hemoglobin F, because we've known that hemoglobin F is a great way to prevent complications, modifiers of hemoglobin, and coagulation pathway. The molecules that I've highlighted in yellow are the ones that have been FDA approved for use in sickle cell disease. And in this talk, I'll focus predominantly on the cell adhesion pathway, and to some degree on hemoglobin F and on voxelotor. Looking at hemoglobin F once again, it all started in 1948 when they discovered that newborns with sickle cell disease do not really manifest any significant clinical problems related to the disease in the first 6 months of life. And it's only after 6 months of life, and that switch happens from hemoglobin F to normal hemoglobin production, that babies started to have complications or issues in this disease. And then they realized that patients in Saudi Arabia and India who seem to inherit another haplotype or seem to have increased hemoglobin F had a very mild sickling disorder. So looking into the solubility of the molecule, they realized that the solubility of the mixture of equal amounts of hemoglobin S and F is twice as soluble as that of hemoglobin S alone. So everyone got really fixated on trying to figure out how to increase hemoglobin F. So in 1982, Joseph de Simone showed that if you administered 5-azacitidine to anemic baboons, that could significantly stimulate hemoglobin F synthesis. And people got really excited and started to explore this in humans. And some investigators have hypothesized that 5-azacitidine increases hemoglobin F production by accelerating erythroid cell differentiation rather than hypomethylation of DNA. In other words, as the bone marrow starts to recover from the cytotoxic effects of the chemotherapeutic agent, erythropoiesis is accelerated and then hemoglobin F is induced. So this proposed mechanism of induction is similar to the mechanism of induction of hemoglobin F after significant blood loss. So to support this hypothesis, experiments were performed to show that hydroxyurea, which is a newly discovered S-phase specific chemotherapeutic agent with no DNA demethylating activity like 5-aza did, could also increase hemoglobin F production in baboons and in patients with sickle cell disease. So the first trials were successful, leading to a large phase 3 trial, or the MSH trial, which changed the treatment landscape. The MSH trial showed a decrease in vaso-occlusive crisis annually, as measured annually, and at secondary endpoints, decreased in time to a vaso-occlusive crisis, decreased incidence of acute chest, and patients receiving transfusions. As you can imagine, this is a huge breakthrough for a disease until then was uniformly considered to be mortal or fatal to patients under the age of 30. Since then, there's been an explosion of trials trying to harness the same pathway to increase hemoglobin F. And this is from a paper in 2016 with summarizing all the trials that had been done and that are ongoing. And I'd like to point out decitabine, which is another ongoing trial at this point. Gene therapy has also taken the same tact, and there are a number of trials focusing on hemoglobin F production. The first one that actually completed with Bluebird didn't look at hemoglobin F, it looked at a different type of hemoglobin induction, but the other ongoing trials are pursuing the same mechanism. So by the early 2000s, what I learned in medical school, and I'm sure most people learned in school, was this whole RBC paradigm for vaso-occlusive crisis, which is that sickle hemoglobin can cause damage to the RBC membrane from deformation by polymer formation. You have this random precapillary obstruction by these really dense SS RBCs, or you'll have addition of low density SS RBCs and reticulocytes in the postcapillary area, resulting in blockage or blood flow and essentially a traffic jam. And then there's damage to the red cell. And because there's damage to the red cell, there's damage everywhere, so on and so forth. There's basically ischemia reperfusion injury, release of free hemoglobin, and heme secondary to RBC lysis. Now, while all this is happening, something really cool is happening within the field of glycobiology. In 1989, the selectin family of cell adhesion molecules were discovered. And through the 90s, the function of these molecules were elucidated. To introduce the players in this system, there are three players: the P-selectin, E-selectin, and L-selectin. And this is sort of named after the molecule, after the cells they were the first discovered on. And naturally, you can imagine P-selectin was first discovered on platelets. So this is stored in viable polar bodies of endothelial cells and in the alpha granules of circulating platelets, and is rapidly mobilized by merging with the plasma membrane. And this participates in the tethering and rolling of leukocytes. So leukocytes need to bind onto P-selectin to attach itself to the endothelium when there's an inflammatory signal. E-selectin is expressed on endothelial cells and upregulated within hours of cytokine activation. So if there's a whiff of TNF-alpha or IL-6, E-selectin gets pushed out into the endothelium because there's a signal out there that inflammation happens. And this is really critical for these long-lived shear-resistant bonds to bind onto leukocytes, so they can actually hold on to the endothelium and extravasate to rush to the site of inflammation. So to summarize this in a sickle context, inhibition of P-selectin delays vaso-occlusive progression within the initial hours of an inflammatory insult, while E-selectin is responsible for sustained recruitment and long-term vaso-occlusive crisis. So naturally, people started to wonder if selectins had anything to do with adhesion in sickle cell, which was elucidated through these papers. As you can recall, the prevailing view in the early 2000s was that all the bad stuff happened due to the RBCs, or the polymer theory. But in 2002, using intravital microscopy in mice expressing sickle hemoglobin, Frenette and colleagues showed that these red blood cells bind to adherent leukocytes in inflamed venules, producing this vaso-occlusion of cremasteric venules. But if you had SS mice that were deficient in P and E selectins, you didn't have leukocyte recruitment. And if you didn't have leukocyte recruitment, you didn't have vaso-occlusion. So this is a big change. It wasn't just the polymers, it wasn't just the RBCs. You had leukocytes in the picture as well. So to recall neutrophil recruitment, it's broadly conceptualized as three sequential steps. The neutrophils have to roll, then they have to stick to the membrane, and then they have to get through the membrane or transmigrate. The interaction between the endothelial cell selectins, the E-selectin, and the glycosylated neutrophil ligands like L-selectin and PSGL1, all these work together to promote neutrophil rolling along the vascular endothelium to these catch bonds and these slip bonds. So the new model of sickle cell disease is that vaso-occlusion arises from the cascade of interactions among RBCs, neutrophils, and endothelial cells. So first, there is activation of the endothelial cells, which leads to recruitment of neutrophils. And then there's adhesion, which is mediated by these integrins. Now, adherent neutrophils have the second wave of signals that's transduced through E-selectin, leading to more activation of the remaining surface area within the leukocytes called MAC1. And this enables capture of circulating sickled RBCs, producing a temporary or prolonged obstruction of the venular blood flow. To make matters more complicated, neutrophils can also burst to form something called neutrophil extracellular traps, forming little microthrombi out there. The addition of platelets or these sickle RBCs can also activate the other endothelial cells. So what you basically have is this propagation or a waterfall that keeps happening because of a little bit of inflammation that was triggered in the beginning. So naturally, investigators wondered, if we blocked E-selectin, would something work? Would it work to reduce the vaso-occlusive crisis that these patients suffer? Would it work to reduce pain crisis? So patients with SS disease, SC disease, SC in this trial, which is not done in hydroxyurea, sickle beta 0 and sickle beta plus within the ages of 16 to 65 were enrolled. They had to have had a pain crisis in the previous 12 months. They could be on hydroxyurea, but had to be on a stable dose. So they received the drug for about 52 weeks or 15 visits. And the primary endpoint was the annual rates of vaso-occlusive crisis. They also examined other secondary endpoints, which were the annual rate of days hospitalized, time to first VOC, and the number of patients who did not experience a VOC. As you can see here, the high dose of crizanlizumab demonstrated a marked difference in the rate of crisis per year, indicating a 43.5% lower rate with the high dose criz. I'd also like to bring your attention to the number of patients with a crisis rate of 0 at the end of the trial, which is double that of the placebo group. I'm sorry, 15, 7, and 5. Now, these differences became even more pronounced when examining crisis rates based on the number of crises in the previous 12 months. There is a dramatic difference there's a dramatic reduction in patients who had suffered 5 to 10 crises in the previous 12 months. I'm not showing you the safety table, but essentially there were no differences between the two groups. This is a survival plot showing the dramatic difference between the high dose criz and the placebo, which is in green. Now moving on to E-selectin targeting agents. Rivipansel, or GMI 1070, was initially designed as this pan-selectin inhibitor, but it predominantly works on the E-selectin as an E-selectin antagonist with some partial inhibition of P-selectin. Now, as you recall, E-selectin was shown to be critical in the propagation of the VOC crisis. So it's not about preventing, but once you get a VOC crisis, once the leukocytes adhere to the endothelium, the goal was to try and get them to sort of unstick from the endothelium. And so to try and prevent an acute vaso-occlusive crisis, or try to reduce the event of the acute vaso-occlusive crisis. The critical thing to remember about criz was that this was studied in patients in an attempt to try and prevent chronic vaso-occlusive crisis, very much like the hydroxyurea trials. So in the phase 2 trial, it was studied with a composite primary endpoint of a resolution of vaso-occlusive crisis, which is defined as when any one of the following occurred. A 1.5 centimeter decrease in a visual analog scale and transition to oral analgesia, or documentation in the patient's chart that both the patient and the physician agreed that the patient was ready for discharge, or a written order of a discharge was placed. In figure A, you can see time to resolution of VOC, which is substantial. I mean, these graphs do tend to separate a lot, but unfortunately, it was not statistically significant. Figure C, however, was statistically significant and shows the median time to readiness of discharge, which is 72 hours versus 137 hours. I'd also like to bring your attention to the cumulative parenteral opioid usage, which is dramatically different between the two groups. So this led to a phase 3 trial where they enrolled 345 patients. Patients received an intravenous rivipansel loading dose followed by up to 14 doses every 12 hours, or a placebo. And the primary endpoint was, once again, figure C, or time to readiness for discharge, which is statistically significant in the phase 2 trial. There were other secondary endpoints, essentially stuff that they had looked at in the phase 2 trial. Unfortunately, the phase 3 trial failed to meet endpoints. However, a subset analysis showed that if you gave rivipansel within 26 hours of pain onset, that reduced your median time to discharge by about 56 hours. And in general, median time to discharge was reduced by 41 hours, about 5 days, 4.6 days to 5 days. So it was absolutely critical that patients got the dose of rivipansel as soon as they started to feel pain, or at least within the first 24 hours. And as you know, patients with sickle cell disease do tend to hold off on coming to the hospital. There's this whole mentality of trying to battle it out and see if they can ride it out with oral pain meds. And this study showed that if you were able to give rivipansel early on, that would make a difference in reducing the amount of opioids that they needed. If you recall the earlier slide, heparin was another molecule that targets the inflammation pathway, and this essentially blocks P and E selectin. And so sevuparin is a modified heparin that maintains this interaction with P-selectin and L-selectin while avoiding binding to antithrombin. So it doesn't have an anticoagulant effect. It only has an anti-P and L-selectin effect. So this is an international randomized controlled trial. This also targeted acute pain crises like rivipansel. And the primary endpoint was time to vaso-occlusive crisis resolution. Unfortunately, this trial was not statistically significant. The hazard ratio was only 0.89 and did not meet its primary endpoint. So looking ahead, there are a number of ongoing and upcoming trials targeting the adhesion pathway. Inclacumab, which is a GBT drug, is a longer acting version of rivipansel. GMI 1687 is another drug from the GMI stable, and it's another E-selectin blocker. Rifaximin, which is hoping to modify gut flora and reduce the amount of dense white blood cells and reduce the amount of inflammation that's present. IVIG, rivaroxaban, which is a single center trial, and then acetylcysteine. For the last part of this presentation, I'd like to bring your attention to voxelotor, which was approved in late 2019 through the HOPE trial. Now, voxelotor is a stabilizer of sickle hemoglobin, and it improves oxygen binding capacity. And because there's more oxygen binding, cells do not polymerize. The hemoglobin molecule does not polymerize. And so when you don't have polymerization or as much polymerization, you don't have as much sickling, you don't have as much RBC damage, and thus there's an increased half-life for these RBCs. So for example, on average, a sickle RBC would last about 15 to 25 days. We can push this out to 25 to 40 days. So this is a really innovative study with an innovative endpoint. Until now, most trials looked at trying to reduce the amount of pain crisis that patients faced, either a chronic pain crisis or an acute occlusion. But over here, voxelotor looked at hemoglobin increase. Naturally, they did look at pain crisis, the annual rate of vaso-occlusive crises, but this is a secondary endpoint. Now, this drug showed a dramatic increase in patients' hemoglobin levels. About 50% in the high dose of voxelotor had an improvement in their hemoglobin. There was a decrease in the amount of bilirubin. There was a relative change in the percentage of reticulocytes, so the bone marrow wasn't struggling as hard to push out smaller RBCs. However, do note that within the vaso-occlusive crisis criteria, there was no real difference. A long-term follow-up study was published recently, looking at patients over 72 weeks, and there was an improvement in hemoglobin response in this cohort. Once again, decreased bilirubin, decreased reticulocytes, but no real change in annual rates of VOCs. What was interesting with this trial is that a sense of well-being actually improved in these patients. Since the publication of the initial HOPE trial in 2019, two other papers came out looking at pleiotropic effects of voxelotor on organ damage. So as you can imagine, the first initial endpoints were focused on hemoglobin increase, but these two papers looked at, on one end, looked at leg ulcers, and then the other on albuminuria. Within the leg ulcer paper, this is a subset analysis of the HOPE trial. They showed that 5 out of 5 patients in the voxelotor 1500 group had an improvement in their leg ulcers or resolution, while only 5 out of 8 in the placebo group, or 60%, had an improvement in the placebo group. So 100% versus 60%. And within the albuminuria paper, which is a correspondence, which is a letter to the editor, looking at 5 patients with albuminuria, there seemed to be an improvement in 3 of them, a dramatic decrease from about 1.5 grams to 500 milligrams. So exciting times ahead, because there is a potential off-target effect from voxelotor in terms of reduced hemolysis and then subsequently reduced organ damage. And that concludes my talk for today. Thank you.
Thank you very much, Dr. George. We have time for some questions now, and you're welcome to add questions to the chat, which I can relay to Dr. George. Or I think, Rachel, are our participants able to ask questions verbally as well, or just through the chat?
Yes, you can raise your hand, we'll unmute you, and we'll keep an eye on the chat and Q&A for questions coming in.
Perfect. And while you're thinking of questions, I can start us off by asking how does a patient navigate these options of treatment? I mean, these are new options in the last 5 or so years, and so what dictates who might benefit from these new treatments and how they go about choosing among them and getting them? What's that like for a patient?
Absolutely.
Also,
absolutely. So that's a very sticky question, because I think purely as clinicians and as the trials had very defined endpoints. So crizanlizumab, for example, or L-glutamine, looked at reducing pain crisis. And for most patients with sickle cell disease, it's about how can I improve my quality of life? How can I improve my pain? So on one hand, you have drugs targeting the pain pathway and trying to prevent pain. So hydroxyurea, Criz, so on and so forth. So if the patient's primary concern is I need to reduce pain, help me, that's the pathway I would direct them to. If the primary concern is fatigue, I'm not feeling too good, my kidney function is worse, my kidney doctor has put me on a ton of erythropoietin and it's still not getting my hemoglobin up, then that's a patient population that I think of voxelotor for. There is a huge group of patients over the last 20 years that suffered childhood strokes, unfortunately, that have been put on exchange transfusions, and they remain on exchange transfusions. I do not change the paradigm for them. It's usually when these organ dysfunction issues start to crop up that you start to think out of the box and ask yourself if there are other options out there. And so in general, it's about pain or decreasing fatigue, and those are the 2 buckets that I like to talk to patients about. And naturally, with the onset of gene therapy, that's another exciting advance on the horizon. Gene therapy trials are focusing predominantly on reducing patients' pain crisis. That's their primary endpoint. So let's see what happens in the near future. And I believe we have a question in the chat box. Are there any trials targeting the neutrophils or NETs specifically with this new mechanism? The only, not really, and it's very interesting when you start reading through the literature, you'll see these small papers crop up that say a reduction in neutrophils or a reduction in monocytes with hydroxyurea use is associated with decreased pain crisis. So I often wonder about this off-target pleiotropic effects of hydroxyurea. When you reduce neutrophil counts, is that because it's reducing the inflammation, for example? I did mention rifaximin, which seems to be the only one that's out there looking at sort of targeting neutrophils. The idea being that you changes your gut flora, and you change your gut flora, you have reduced inflammation or reduced TLR signaling from the intestinal mucosa, which in turn reduces the amount of older or let's say more active neutrophil component. But that's something that's, that's a phase 1 that's potentially about to start soon. So it's all very theoretical at this point, but nothing specifically targeting NETs or neutrophils.
So you mentioned gene therapy as well, and perhaps in parallel, gene therapy is being developed in the hemophilia world as well. How do you think about gene therapy fitting into your treatment paradigm at this point? And where do you think that'll go in the future? Is that going to be widely available? Is it for a very select group of patients? Is it for diseases outside of hemoglobin S? How does one navigate that now as a hematologist?
Absolutely. I can tell you that the gene therapy world in sickle cell isn't as well along the way as it is for hemophilia. But having said that, the endpoints that and as you can imagine, the cost is also a huge talking point going forward. The endpoints focus predominantly on pain crises. So I think in the future, there are possibly 2 buckets that you can put your patients into. One would be, I have patients that have a lot of pain crises in whom gene therapy, in whom existing treatments don't seem to necessarily work. That's one potential bucket. And hopefully when you have more information out there, could this be subsumed into patients who are starting to see other, organ damage from off-target effects of their sickle cell disease? That's potentially something I'm really excited about, about data that might come out in the near future. The biggest problem, of course, is to really get that sort of data, you need large number of patients, and that's something that will probably be in post-marketing part of things. So right now, I look forward to data that should emerge from the numerous trials that are ongoing, which should be in the next 5 years or so. And some I'm sure will succeed, some probably won't. And there are also these worries about secondary leukemioid malignancies that might crop up in these patients. And so at the end of the day, I guess it's going to be sort of balancing reduction of pain versus other complications that can arise as a result of the treatment. But to be honest, Tyler, it's I think it's a few years away. At this point, it's all still, it's new and exciting. It's like where CAR-T was in 2012, 2013. The hope is that you can see the light at the end of the horizon, but it's not really quite here yet.
Right. So still treating with available therapies to hopefully avoid and reduce any effects in the meantime while waiting for this potential.
So Dr. Hassel asked, do you see a role for multimodal therapy using more than one of these approaches? And how do we make that work financially? So in terms of I think what was interesting is a lot of the new trials focus on allow patients that are already on a stable dose of hydroxyurea, for example, to get on the trial. Strictly speaking, this would be an example of a multimodal therapy. I believe my hope is that as more data emerges, in terms of its effects, therapy's effects on other organ functions, possibly mixing and matching some of these therapies might be something that we could explore in the future. The big sticking point is always the financial costs of the new drugs that are being put onto the market. We're talking about anywhere from $90,000 to $150,000. And my understanding is that a few of the drugs that are currently in clinical trials looking at other pathways are upwards of $200,000 to $300,000. And so I'm afraid that's a question that we as a society need to be asking. how much in terms of what makes financial sense, and if the actual efficacy, it really makes sense. It's a conversation that the oncology world has been having for some time, and I'm afraid we're about to join it too.
Are there groups that you know of that are looking at cost effectiveness and taking that reduced number of hospital days or hospital stays or VOC events that translate that into some kind of financial numbers to look at that from a system perspective?
Absolutely. So the ICER, or incremental cost effective ratio organization, the Institute for Clinical and Economic Review actually did put out policy papers regarding these drugs and its cost effectiveness. They used complex modeling, and at this point, it did not. The last I checked, it did not show any effect for voxelotor, but it definitely did for CRIS and for L-glutamine, for example. So yes, there are groups out there looking at this, and also from a national organization perspective, the European organizations and including NHS and NICE study these drugs in great detail before they allow them to be part of their formulary. And so NICE, for example, has approved the use of CRIS. So I think the British have accepted that its cost effectiveness actually makes sense. I hope that's a good answer.
Yeah, that's good. I'm sure will forever be debated.
Indeed.
Okay. Any other questions from anyone? This was a fabulous presentation and review for us of new therapies. I would say as a not an everyday treater for people with sickle cell, that this is a long time coming, that there are new opportunities for improvement in what we can offer people. And I think that that overview was very helpful. I don't see any additional questions, so I think with that we can probably close.
Thank you, Tyler. Thank you, everyone.
All right.